different ulcer in different patients, so you can appreciate this tremendous and robust induction of the ADAM12. I have to say it's kind of a bearer of a bad news in general, and if you look at the bladder cancer, for example, you could find ADAM12 secreted in the urine of a patient whose tumor is gonna go metastases. So I think in a way, kind of alert to the bad situation outcome, clinical outcome. We still don't know exactly how and why in the context of a chronic wound. And this study was done with the Carl Global from Cornell and HSS. So what we have done is we have generated a transgenic mouse with ADAM12, where we actually knock out ADAM12, and obviously when you think about it, so if a lot of ADAM12 inhibits healing, if you knock it out, you will expect that the cells will migrate, and that's exactly what we get. And this is a more visual way of testing the migration on its own, where you actually take the biopsy off the skin and put it in, and you actually measure the outward. So it's kind of an inverse version of wound healing, where you're expecting to close, you're now measuring the cells, how far and how wide they can actually migrate. So, and the staining here is showing that these are actually indeed keratinocytes, because this is keratinocyte-specific antibody. So, in addition to what we already knew about chronic wounds that have increased metalloprotease activity, we actually found an increase of ADAM12, and that may be leading to increased processing and growth factors, changes in interactions with extracellular matrix, integrins, and intracellular signaling, all of which would possibly lead to inhibition of wound healing. So the obvious question is, so what regulates all of this, what I told you, is what are the regulators and what are the main switchers? So we start looking into microRNAs, and I will not really go into details of what they do, but for the take-home message, the important thing is when you have a message, obviously it gets translated in the protein. When you have a microRNA present, that doesn't happen. So essentially, you can actually have a full transcriptional regulation, and you do have expression of the message, and you do have message being made, but then when microRNA comes, it kind of never allows that to turn into protein. And so we thought that maybe if we approach this genomic profiles that we have from our patients, and if we use the reverse genomics with the help of Christina Lester from Sloan Kettering, who is really talented computational biologist. So if you take these genes, the 1,500 regulated genes, and you say, okay, if microRNAs are targeting these genes, which microRNAs would be regulated in that tissue if these are their targets, and that's how they're expressed. And so that sort of reverse computational analysis led to a list of microRNAs that might be regulated in a chronic wound. And so with, again, Irena Pashtar and Professor Steve Davis, who we collaborated on this study in Miami, we started looking in the levels of these different microRNAs, and what we found is that they're all induced, the different levels, but they're all induced in ulcers, and this is one of them. This is the microRNA 21. This is a venous ulcer biopsy, and you could appreciate this is in situ hybridization, showing this profound induction of microRNA 21. So I will not go into details. There are a lot of data there, but in order to shift to the patients and talk about translational aspects, I will not spend a lot of time on this subject. But it's important that we have identified and documented and proved that these microRNAs that we found induced in patients with chronic wounds really target signaling molecules, and they do regulate their expression or their protein levels, if you want. And that is one of the profound and important issues with the chronic wounds, and something that we really clinically need to know. So essentially, if you look at the diabetic foot ulcer, for example, what happens to these cells, unlike in acute wounds when these cells start migrating, that doesn't happen. Then the fibroblasts really stop proliferating, and they do not lay properly the matrix, endothelial cells are not migrating, and there is decrease of angiogenesis. Macrophages don't come in the site of the wound in the numbers and ready to fight infection. And what you have is, in addition to all of this, is really formation not only of colonization, but unfortunately of microbial biofilm. And now this wound turns in chronic and infected, and there is a really bad outcome at the end for your patient. And so how is this achieved? Again, the decrease in growth factor cytokines and chemokines is one of the reasons why none of this really happens. And so turning from healing to a chronic wound and trying to wrap up with what I have said so far is that there is an increase of microRNA molecules in the non-healing wound, and that leads to deregulation of the signaling molecules that, as an outcome on the cellular process, has inhibition of migration, hyperproliferation, and loss of local stem cell cycling, and their loss in the area of the non-healing wound, and then obviously loss of differentiation. All of this really inhibits wound closure and epithelialization. And wound is not healed unless it's closed. And that means until keratinocytes do their job, the wound is not closed, and therefore there is no healing. And keep in mind, obviously, that I haven't talked about other components. So we are just in epidermis, so this is only one aspect of the whole process. And I could not list all of the participants, but, you know, we didn't discuss today granulation tissue formation in the context of chronic wounds, nor angiogenesis, or the crosstalk of the microbial biofilm and chronic wounds. So clearly we have our biobasic science world completely cut out and work cut out for us. Now, the biggest question that there are many labs tracking this and trying to understand it is why and what is really what is upstream of all of this. So what regulates these microRNAs? And not only microRNAs, they're not magic molecules, but they do participate. So I don't want you to go home and think, oh, it's easy, we can just reverse these and we are done, but that's not going to happen, right? So I think that understanding what comes upstream of all of this that I have told you will be really important, and that's where the excitement right now is, and there are a lot of work being done on that. But essentially, again, conceptually, from this healing to a non-healing, right? So you can really think about it in two ways. So either the cell has transitioned and crossed over to the world and it cannot go back. So this is sort of terminal. It's non-healing and there is no way back. Or this cell has to, undergo and underwent really a bad set of decisions and signals and God knows what else, and end up not healing. But there is a hope, and switches can be reversed, and they can really be transitioned over. And actually, both of these are clinically valid approaches. And so when I talk about the first part at clinical meetings, they all shrug shoulders and say, so what can we do today for our patients? And so the current approaches are two. Obviously, one is remove the non-healing cells, and the other approach is reverse their fortune. It's very simple if you think about it. So either you can just cut them out and keep those that actually do have healing phenotypes, or you can try to really convert them. This might be maybe more difficult, but then maybe more permanent solution. And so both of them are clinically valid, and they're being implemented today in the clinic. But it's not that easy, really, when you have removed non-healing cells. So what does that really mean? How do I, when you look at the wound, how do you know which one is really non-healing cell and the tissue part, and how you're going to cut it out if you don't know? So we clearly need something more of sophisticated approach to really create this what we call molecular scalpel, where we can really know and guide the extent of surgical debridement in the chronic wound and really removing this tissue. So if you look at the concept of Mohs surgery in skin tumor cells, so what happens is that when a tumor is in the skin, the Mohs surgeon comes and they cut out the tumor, and then they analyze it on the microscope while the patient is still on the table. They look and to see on histology whether they're efficient in removing the bad tissue. So is it all tumor tissue gone? And if it's not, they go back and then resect, and until it's completely clear and histology shows the normal skin tissue, this patient is still in the room and is being treated and debrided if you want. So if we borrow that approach and we use that strategy to really try to degrade chronic wounds, then we clearly need more, obviously more than just the microscope and the histology, but then we can really analyze this tissue and try to come up with something that will tell us how far to go. And therefore, in development of these biomarkers, any possible way imaginable, and I will show you the approaches where we are at that stage. But the bottom line is, so if you can tell what is a non-healing tissue, even though it might not happen because we still don't have a really quick method to do this, but if you actually know that you haven't degraded the patient far enough, then you might go and redegrade that more efficiently, maybe as quickly as you can, to really get that patient going. And so is there any biological basis to what I am telling you? The other important question in the clinical arena of wound healing is can we tell when a patient comes in on that first visit whether if we apply standards of care, this patient will go on to heal, or do we have, or it will not? And so the question of predictive biomarkers, whether we can really predict clinical outcomes early on, will clearly define how we are going to treat the patient. Because then I have to spend a little more time explaining you why this is important. Today, what you do is you apply standard of treatment protocol for 4 weeks, and then you're measuring the size of the wound in every visit and dressing change, and then you're looking whether that wound has healing trajectory, and if it heals greater than 50%, that patient will heal with the standards of care. But if by week 4 this does not happen, then biological applications, then different treatment protocol gets implemented, and more biological treatments are being offered to that patient in order for them to heal. So, and this is basically based on a work from David Margolis, who really has shown that this that 4-week outcome is really a surrogate endpoint, and really, really important to really know that. So if we don't have to wait for 4 weeks until we actually have the patient who is not healing, it will be tremendous clinically if we can tell that from the first visit and really start a very aggressive treatment plan from the get-go. And of course, not spend a very expensive biological treatment on patients who really don't need it. So there are two different benefits of this approach. And so what we have set up to do is we decided to collect specimens before and after surgical debridement and really run all the possible analysis. So in addition to microarrays, we have grown primary cells out of these wounds and studied them in culture, and we also looked at a different variety of analyses on histology and immunocytochemistry. And one thing becomes immediately apparent, and that is that on this non-healing edge of wound healing, or non-healing wound, I told you what happens in epidermis, but this is sort of a dermal site, and you could see that there is a profound level of fibrosis that kind of resolves partially in this pulse debridement biopsy, and this is how normal skin looks like. But one thing was striking because, granulation tissue really is always a big problem in the chronic wounds, and I always thought that there is not enough collagen. But when you look at pro-collagen staining, so the cell basically makes the pro-collagen and kind of spits it out and lays it out as a matrix. So if you look at the pro-collagen that's still being made in cell, you could appreciate that there is a lot more cells making collagen in a non-healing wound than a post-debridement biopsy. But yet when you look at the collagen orientation and when you look at the polarized light and how this collagen matrix is laid out, then you can appreciate that really this in a non-healing edge, this really it's not done properly, and this obviously contributes to the lack of migration on the top of epithelium. And again, the post-debridement biopsy looks a lot better, and this is how the normal skin looks like. So obviously, striking differences as you would expect in gene profiles. So again, this is a non-healing profile, and it's tremendously different in post-debridement biopsy. And so if you think about, these are all the cells as a part of that wound. And so there is clearly a set of cells that have not only different profile but different healing potential within that wound. And being able to really reach out to them and find them and stimulate them to really come and do what they're so well known to do would be really tremendous. And if you think about this, it's another aspect of it. We can actually use the gene profile to tell us whether we are far enough, and I will show you a little bit later of how we can achieve that. Now, when you look at the primary cells grown from the wound, that non-healing edge, you can again. I'm not sure how far whether you can appreciate this resolution, but these cells are really look thick. They don't look normal. They're really big and large, and they don't move at all. And when you look at the cells from positive Friedman biopsy, clearly they look a lot like a normal cell. So when you try to test their migration, so I have to say that I was a big believer when you grow primary cells out of non-healing wound and put these cells in all the goods of growth factors and cytokines of the growth media, then these cells will revert right on and there will be no difference when you grow them long in culture. But interestingly enough, not only they don't grow well, but they also do not migrate and don't respond to growth factor signals at all from the non-healing edge. But the positive Friedman biopsy is a completely different story. These cells are actually able to migrate, and then, as I said earlier, and you could, those of you maybe sitting in the first rows, you could appreciate that there is a lot more cells on this side than here, so clearly their proliferative capacity is different and better. So again, this is all sort of contributing to the biological basis of the Friedman approach, and yes, there is within the non-healing wound, there is a subset of cells that are able to respond to growth factors. They're able to migrate and probably complete the healing. So again, finding that region and finding that debridement margin and distinguish the tissue A from tissue B, non-healing from a healing potential phenotype is really a big question, and that's what we were set to study. And of course, our wizards look slightly different, and this is a wound healing clinic. This is Rob Kersner and Steve Davies and so this is the research and clinical team put together that really is trying to figure out these biomarkers. And every once in a while you will actually get a slide that looks like this, and that's really quite exciting. And I'm sorry there is not enough right here maybe for you to see, but the non-healing edge, this is a staining for beta-catenin, and what we are looking for is nuclear presence. Nuclear presence is bad. Absence of beta-catenin in nucleus is good healing outcome. And so, what we do is we stain the cells and we quantify this in the tissue and really link this to the clinical outcome. And we kind of look at the healing at week 4 or the positive Friedman biopsy. But every once in a while you will get a slide like this, and this is the most exciting. You could almost draw the line of the tissue where you actually have a lot of beta-catenin in the nuclei, which will be healing potential, and the other side where actually has all the nuclei present for beta-catenin. So again, there is the Friedman margin, and I think it's a matter of how sophisticated we are in finding it and developing the right tools to really get there. But this really gives a great hope. And of course, to transition to the genomics approach, we clearly, at this stage, NA might not be clinically feasible and practical for the pure aspect, but in general, it's clear that it can serve as an excellent guide to really determine what is a non-healing from healing tissue. And so if you look at this is the patients, these are 3 different patients before and after the debridement. And again, you could see the profiles, and then this patient obviously had something different. And it turns out that this patient was not debrided far enough, and this is really a non-healing profile. And indeed, when we did all the stainings, and of course when we went back to check the clinical